Hi friends, today we'll be discussing about the orthopedics which comes under surgery paper 2 PP2. Okay, so basically you'll have two papers in paper 2 of surgery, 50 marks comprising of your systemic surgery and 50 marks comprising of your orthopedic surgery. So this is the marks distribution which is followed. You will get one question for 10 marker and four question for 5 marker, five 3 marker question and 5 MCQ. Okay, so how I am going with orthopedic is that don't get uh, frustrated or something because ortho is such an easy topic. It has a easy narration. Okay, the whole ortho topics are divided into as per the university. There are 13 major topics. I have divided into 16 and rest of the topics because these 16 are the one where they according to blueprint you can expect a 10 marker, and remaining are the one where you can expect 5 marker or a 3 marker. Okay, so those 16s are fractures. Mostly you might get a supracondylar fracture or a infection or a TB, metabolic bone disease, tumors or congenital lesions, and these we will discuss. Okay, the core idea is to cover 10 mark related topics first so that you cover even 5 mark thing. But 3 markers are specific and we'll see how to go about it. Okay, this is what the expected blueprint, predictable questions which I feel. See, ortho is an easy topic provided you know what to learn, because you just have not even one day of time. You might get half day, so you should know what you should learn. So for 10 markers you have to study osteomyelitis, port spine for TB, and supracondylar fracture. Make sure you study the FOSH, that is fall under Auschwitz injury. Okay, then go with bone tumors, and also not all bone tumors. You will have only osteosarcoma or GCT and CTB. These are the predictable questions. See, out of 6 which was there, and they university has the authority to take any questions. But I feel in fracture, supracondylar fracture is important. In infection, osteomyelitis is important. In TB, port spine is important. In tumors, osteosarcoma and GCT is important. And congenital lesions, if they want, they can ask for they can ask only CTE for 10 marker. And remaining metabolic bone disease, all these rickets are there, but they are not potential 10 marker. They can definitely come as 3 marker or 5 marker. Okay. Then remaining, this is about the 10 marker ka prediction. I am sure out of 6, anything they should ask, man. Something around in and around this will come. And for 5 markers, these two, first or any two, okay, any two out of 4 questions which they are asking you for 5 marker, it will be from somewhere here itself. So that's what that's why I told you the importance of at least 1 month, one or two, okay, will come from this part which you are studied for 10 marker itself. One question has to come short from nerve injuries, which we'll be discussing what are the questions, and one question related to arthritis part. It might be either degenerative arthritis or rheumatoid arthritis, or either you might get a question from hip, that is posterior dislocation of hip or neck of femur fracture. Okay, these are the predictable 5 mark questions. Next, 3 markers. Make sure you answer to the point and come back. Okay, no doing bullshit because you don't have marks. You just have 1.5 hours. So idea is first to attempt 3 marker, then attempt 10 marker and show the clarity of the topics which you have, then attempt 5 marker. Okay, because here you have almost 20 marks. Here you have almost 15 marks. Okay, but here combining this you get 25. So make sure you have, everybody has a separate plan for that. Definitely you can follow anything. So one question related to splints and tractions or any instrument is a sure question for 3 marker. Okay, then 3 mark other might be something related to spine. Here even in 5 marker you might get, but something related to spine, a question has to come. A question something related to soft tissue, for example tenosynovitis, trigger thumb, then golf elbow, tennis elbow. All these questions are very important and should be asked for 5 marker or a 3 marker for a fact. Whenever you sit in a OPD of an orthopedics, these are the things which you encounter more after fractures. So an idea, a sound knowledge of soft tissue injuries is a must not only for your exam but also for your practice. Okay, then obviously one question related to metabolic diseases like rickets, clinical features of rickets, x-ray features of rickets is important. I have made it in a tabular way so that if you present you can fetch the full 3 marker which you want. And something related to fracture, for example complication of a fracture, non-union, malunion, or any complication of a fracture for or for any other things, for example Volkmann ischemic contracture, all those things are also important. We'll discuss accordingly. We'll place the disease like how we did for medicine, and we'll go about it so that we don't waste a lot of time a day before exam, and also we give some amount of time to surgery paper too, so that we can score good marks in both the papers. So this is the general overview. Make sure you know, study this part first, then you go for this. See, again I want to talk a few things about poliomyelitis and cerebral palsy. Though these are these are included in competency, not much of the questions are being asked. So make sure you study something about cerebral palsy and poliomyelitis. Okay, something. Okay, so that you never leave any question blank. That's it. Okay. Okay, coming to, we will follow the same approach. 10 marker bar 5 marker is predictable, so work for that. 3 marker is on the day of exam, provided you have a good knowledge of whatever orthopedics you have studied in the whole year or remaining 3 years. So fractures, these are the questions according to Singhi and your Maheshwari. And musculoskeletal infection, these 2 lessons has to be covered. And under TB 23 part of your Maheshwari, and metabolic bone disease, it's 17 if I am not wrong, and bone tumors is 28. Congenital lesions, these are the questions. Those 6 units are included. We feel the most important one are acute osteomyelitis, port, spine, and bone tumors. And also under fracture, these are the only 2 questions which we are expecting for 10 or 5 marker. That for 10 marker, 5 marker can come anything. You can expect anything. That is supracorneal humerus fracture and posterior dislocation of it, or congenital lesions of CP. Out of all these 4, no, any one you will get. Make sure you study this first, then you come. Okay. Okay. Let us jump into the discussion first. Okay. Musculoskeletal infection. That is the 22 lesson of your Singhi or Maheshwari, whatever you are following. These are the questions which are asked. Okay, you might get an acute osteomyelitis case or a chronic osteomyelitis case, and also these are the 3 markers which you are expected to know. Definition, that nothing but first you need to know. Everybody will learn it is due to the infection of bone. Important thing is the the duration. Then this is the classification. You can write any classification because you are write all the classification because you are writing for 10 marker. Then etiology, most important thing is staph aureus, you cannot miss. And because it's a 10 marker, make sure you also mention about sickle cell disease, IV drug users, and diabetic food also, and also neonates. Okay, pathogenesis, make sure you draw the diagram, see that, and also make sure you highlight the growth plate, and also where is the abscess is being formed. You can, I am sure at the metaphyseal end you have to make sure the blood vessels are like that. And how does it happen, then how this is the, see, first of all the bacteria enters to either direct route or indirect route. The direct route is through the open fracture, indirect route is through the hematogenous. Okay, then again what will be formed? Abscess is formed. Then again what is formed? After an abscess is formed, it communicates to skin. Then this is a part of what? All this is a part of your chronic osteomyelitis. So make sure you mention that part as well. After an abscess is formed, if you have a good if you intervene early in the natural history of disease, then the person will never go into chronic osteomyelitis. But if you treat inadequately, or if the natural history of the disease is not intervened, then obviously the person will go to chronic osteomyelitis, after which you will form after abscess is formed, it will going to drain out. Then this will form the dead bone. This will form the sequestrum, which is the dead bone. Then all you will have first, after it's being drained, you will have the periosteal reaction. Then all this pus will come out. Then the dead bone, which is formed as known as sequestrum. Okay, I just explained the natural history of disease so that you know how to go about it. Then pathology, this is how as far I have explained, this is the same thing. How I have also this I have elaborated a bit more. how it goes to cortex and how it goes to the other part. So basically you have to know that there are only two blood supply to the bone, that is endosteal blood supply and periosteal blood supply, correct, no? So based on that, you these are how to the medullary cavity or the cortex, how does it go, is what I have explained in this pathology. Okay, then again, gross and microscopic, you might have metaphyseal abscess or elevated periosteum, and microscopic, again the same acute signs of inflammation you can write for clinical feature, because it's acute infection you can say about neutrophils, and don't mention about necrosis because it's a part of osteomyelitis, that is chronic osteomyelitis. And clinical feature, general and local. There's nothing. One thing which people forget is about the pseudoparalysis of limb and also refusal to bear weight. Examination, again at the metaphyseal area you will have swelling, you will have pain. Okay, then investigation, always write in, because we are writing a 10 marker or a 5 marker question, study accordingly. Again here it's to establish diagnosis, to identify the causative organism, and to assess the extent of local and systemic involvement. So to establish diagnosis, what are the infective protocol which you will follow for any infection? You have blood investigation, you have what are there, CBC, ESR, CRP, and also here, since if you wait for X-ray to diagnose you, who are you? You're a fool, because you have to order an MRI and diagnose as soon as possible, because it is more sensitive. Then you have to identify the causative organism. You have to go for blood culture, and also you have to know the systemic involvement. These are the differential diagnosis. Make sure you write rheumatic arthritis, rheumatic fever, and septic arthritis. Treatment, again, aim. Patient is in pain, so give analgesia, then give hydration and control fever by paracetamol. Then mainstay of treatment is medical. Only in chronic cases, orthopedicians will come into action. Even in that is surgical comes into action, but you have to mention about all these things. If it's 48 hours of onset of symptoms, then these are the drugs which you will give. Because here, what did I say? The most common organism is Staphylococcus, and staph is notorious to have, yes, MRSA. There are also VRSA which are there, but for methicillin resistant Staph aureus we give vancomycin, and again it is sensitive to ceftriaxone. So that's how integrate all your pre-paraclinical and come to an answer. Then again, if it's more than 48 hours, it is an indication to drain the abscess. If abscess form, before draining the abscess, don't give antibiotics. And these are the supportive care which you need to do. Then these are the complications, which I'm sure you can just study. So while writing complication, make sure you write about growth plate disturbances and pathological fractures, because there are incidences where people present at this stage as well. Okay, coming to that is one of the 10 marker. Make sure you know about that. So what did we revise in this part? First thing is about knowing knowing about the definition, less than 2 weeks of onset. Then the classification part. Then the etiology, majorly focusing on Staph aureus, and also the other etiologies which are there in a different subset, pathogenesis, and we understood the natural history of the disease. Then we talked about the clinical feature. Then also the investigations with aims, treatment with aims, and why I had explained why ceftriaxone and vancomycin is also being given. Then for chronic osteomyelitis, it's the same thing. These are the types, but what is the pathology? Again, I have explained the natural history of disease there. So first, the periosteal bone is formed, then the thickening of bone, then there is a sinus formation, then it gets fixed. Then again, all those things will the abscess which is there will come out. Then it forms a sequestrum. All those things you need to explain, as I explained earlier. Then again, here the major thing what the pain is about movement, painful. You will have low-grade fever, malaise, and loss of weight. But defining feature of chronic osteomyelitis is chronic discharging sinus. Okay, these are the examination findings. I'm sure you can just read about that. And investigation, again, investigation based protocol, and also radiological investigation to know the extent. Okay, principles of treatment here, it's basically a surgical thing. Only antibiotics are given after post-operative stage. Though these are the modalities which are involved as an operative procedure, all the things are or is tailor made based on when the patient present, or based on the patient's age, based on the extent of bone destroyment. Okay, so first we won't take up the patient for surgery and directly go with sequestectomy or socialization. First what we do is we plan based on the patient profile, we go with the infected part of the bone, then we go remove the dead bone, then we see what is the important thing which we have to manage is the major principle is remove the dead bone. Okay, then fill the dead space with bone cement or bone graft. So after removing the dead bone, obviously you'll go with, if you want you can go with curettage or saucerization. Okay, then if it is required, you can excise the bone to an extent. But do we do amputation these days? No, we are not in that era of India. We are, though there are incidences where they go for amputation as a last stage, but we have many techniques in orthopedics where we won't leave patient to go till that, provided they come at the correct time when they have to come. Okay, these are the complication. Again, the complication of septic arthritis is important. Again, whenever you are writing complication, make sure you divide into, in ortho, divide it into general and local and place it accordingly. Okay, now, there's nothing much to explain. One important thing which you will write about is irreversible cartilage destruction, which will lead to secondary osteoarthritis and also the epiphyseal damage. Okay. Brody's abscess, what happens here is, I will just explain you the concept here. The immunity of the person is very good, so that the pus is being localized here. Okay, here the major goal is to remove that, evacuate and cover it with antibiotics. That's the major thing. Then sequestrum, again these are like for 3 markers question. Okay, as I explained, it's the same thing. Make sure for 3 markers you should know what to write for 1 page. So you should know the types of sequestrum. Where will you find tubular? That is in pyogenic. So T and P looks the same, right? Then where external fixator is to ring fixator. So again ring sequestrum is seen in external fixator. Actinomyces, you will see black color. Okay. So what is inward Vikram? So though these are the questions which was previously asked for 3 marker, now they are not asking, so I've just mentioned it. Okay, obviously you know it's a dense sclerotic bone formed by the periosteum around the sequestrum, and it will be more densely white. Okay, that's one important thing. It's clinical significance, it's a sign of chronic osteomyelitis. And how will you see next step? So 3 important features, you will write it for 3 markers. Then 24, that is according to Singhi or Maheshwari, it is infection of night, infection of ant. Though these are not for 10 marker or even for 5 marker. One question which I would like to ask you to concentrate is for acute paronychia. We can refer these pages, though I will just write about the management here. So one thing, you can go with antibiotic coverage if you cannot see any pus. But if you see pus, what is that? High incision and drainage. That's it. According to, again, this is a super specialty itself in orthopedic, that is hand and microsurgery. But this is one thing which they can ask, but there are no RS question as such. Okay. Coming to the next part, that is skeletal TB. So 10 marker is this. Then these are the 3 markers. But one thing which I can expect for 3 mark is only this. Okay. Make sure you study this than this. Okay. Only once I think they have asked this. So again, what are that Potts spine? We'll discuss about Potts spine under tuberculosis. So this is what, make sure you draw this diagram. Okay. See what happens is, the blood supply of vertebra goes like this. So whenever it is affecting, it will affect both the vertebrae which are adjacent. So paradiscal is most common. Then it can be central and it can be anterior, or it can also be at the posterior side. So make sure you draw this diagram, and that should be enough. Pathogenesis, again it's the same thing which you are writing for TB, but here you will show that it's also coming to vertebra and developing the abscess. Make sure you write that diagram of what I have mentioned, so that you can fetch the full marks. Okay. Then clinical feature, always whenever you write for clinical feature, mention about TB specific symptoms, then local symptoms, and any local deformity and any neurological features, because we are talking here about spine. Okay. Then again examination, again to pick up signs or suggestive of TB. Then again if there are any complication, and these are the other examination ka aim. Again, here investigation is to confirm diagnosis first, then assess the extent of disease, because there is a chance of a person going to post paraplegia, and detect any complication if any. These are the differential and principles of management is to achieve complete healing and to prevent complications such as paraplegia. This is the major aim. Okay. So how do we plan about the treatment? If there is no paraplegia, then obviously we start with HRZD, then general spine care of the patient, that is immobilization, all those things. Then if there is a cold abscess, then if it's small, obviously you can just go with ATT, but if it's a large, you have to do an aspiration in the anti-gravity insertion way. Okay. Otherwise you will have cutaneous TB. Okay. So one important thing what Indian had to give about an Indian contribution to pot spine is that we didn't know whether a person has to be just given ATT, or whether it has to be surgically taken up. So we entered a different part where we started with this, then we assessed that prognosis, then we started going for surgical indication if any. So just an idea on the history part I just wanted to mention. Okay. Now, this is the treatment protocol for TB. Though it's not an important question now, you can just go through this part. I just pasted the Maheshwari part photo here. There's nothing more which you are expected to know here. So basically, you have to know whether the osteoarthritis part is being there, and also whether if there is a total fusion of the joint. If there is total fusion, then you have to go for orthosis, or it's not an important thing, so you can just leave it. So bone tumors, again, these are the important the classification question might come for 10 marker itself, and these are the important 3 marker. Again, right with the WHO classification of bone tumors. Again, I will just give you a concept over here. So what is orthopedics dealing with? You have your bone and you have your cartilage. Again, in bone, what are the 2 types of cells you can see? Osteoblast, that is bone forming or bone destroying. And again, what are the things which are there in medulla? Hematopoietic cells. So based on this, let us apply. So bone forming tumors, that is osteoblastic tumors. It can be either benign, intermediate, or malignant. You can forget this part for the sake of convenience. So what is the benign thing which you see? Osteoblastoma or osteoblastoma. But malignant part is osteosarcoma. Then again, cartilage. Okay, cartilage also you have either benign or malignant. Benign is osteochondroma, and whenever you are at sarcoma, it is malignant part. And benign aggressive tumor which is there in the diaphysis is one more, that is GCT. The hematopoietic neoplasm, again, which I mentioned here, that is multiple myeloma or lymphoma. Neuroectodermal, again, which is present near it, is Ewing's. Then again, you might have any vascular tumor, because even bone has vascularity. You might have benign condition like hemangioma, and malignant conditions like angiosarcoma. Then others, again, second is the most common bone tumors. So I have to obviously mention about that. Here I think I discussed about osteosarcoma here. So while writing the etiology, make sure you draw this graph. That is, you have 2 peaks of getting osteosarcoma: adolescence and old age. Genetic and any pre-existing bone disease you have to mention about that. Then who is the pathology? The same thing. I am not explaining much on this, because sure you have studied in pathology itself. And you have primary and secondary. Secondary is with underlying any other disease. Again, clinical feature, always write general symptoms and systemic. In that you can mention about local. First is pain followed by swelling, or the patient can come up with pathological fractures. Again, they have mentioned rarely weight loss, so I have not included on the journey. Again, swelling in the region of it's a metaphyseal tumor. Again, you have to mention about all these things. Then investigation, again, to confirm the diagnosis, to detect if there are any distant metastasis, and to plan for treatments. You can do the pre-op investigations as well. Again, the aim is to stage the disease, execute adequate treatment, and confirm the diagnosis and prevent recurrence. Okay, that is also one more thing which I would like to mention. Okay, then again, staging based on the involvement of bone and spread of other tumor, you will do that. For treatment, again, you have to do local control and micro and macro metastasis control, for which you give chemo or immunotherapy. Then again, if for local control, we will go with either limb bearing surgery or amputation based on the involvement of osteosarcoma in the bone. Okay. Again, you have to come for follow-up after. So this is the same thing which is there in masonry. What we do is, though this looks very vague, first thing is you take X-ray and of bone as well as chest X-ray to look for metastasis. If there are metastasis, then you have to start with chemotherapy. If there are only if there is only one metastasis, then you can plan of resection followed by treatment. But if it's multiple, obviously it's a palliative chemo. Okay, if chest X-ray is normal, then you look for you have to there will be two aims. Okay, you have to control the local micro metastasis which has occurred, which might have occurred due to local chemotherapy, due to by systemic chemotherapy. But local control, we orthopedicians will come into actions where you have to do either limb ablation surgery or limb saving surgery based on the involvement of. Okay, granular giant cell tumor. This, as I told, it's a benign aggressive tumor. Again, the origin, cell of origin is something which is important, which you will write it here. Then again, clinical features. Again, I just made a graph so that it looks, you know, better. So again, general and systemic and local. These are the things. Major thing is examination findings, where you find tenderness and palpation and external crackling, which is pathognomic. Same investigation ka aim, make sure you write it, but X-ray appearance, you make sure you write it better. That is soap bubble appearance. Okay, the mainstay is surgical here because it's a benign locally aggressive disease, though there are malignant part of it. But while writing, excision is the main thing, and you have to curettage it with. Then you have to fill the curettage, or you have to fill the part with either bone cement or bone graft. Then obviously you have to do the reconstruction part. You cannot just leave and go, right? So you have to write about that also. Then Ewing's, it's a possible 5-marker question. When 10 markers are not asked as osteosarcoma, GCT, then obviously for 5 marker you can expect these kind of small tumors. Okay, so whenever you are writing about this, make sure you write, you underline the things which I have, or you box out the things which I have done. Again, cell of origin. Then under pathology, what you see, a major differential, where is the location. Again, to investigation, while doing, you will also have X-ray which shows onion peel appearance. Then also to look for metastasis. Differential is osteomyelitis, and also these are the chemotherapy regimens which you follow. Okay, again, 5-year prognosis is 70%. Osteochondroma, it's the most common benign tumor. Okay, again, the same thing. I am not explaining this well because it's not that important. But one important thing which is important for 3-marker is how will you assess whether it's a benign or malignant part. If the capsule size is more than 2.5 centimeter, or if there is any evidence of growing the tumor is growing large, then you have to suspect whether it's going from benign to malignant. These are the complications. Okay, you can just write about that. Okay, so 3 markers, make sure you know what to write and what not to write. This is again one of the enchondroma things, which is whenever you see enchondroma, obviously your small bones has to come into mind. So based on that, you have to address the things. So obviously you go with curettage with multiple bone grafts, filled with bone grafts, because you have curettage. Then osteoid osteoma, this is the most common benign tumor. Make sure you write this, and which response excellent to salicylates is something which all examiners would like to see. Okay. Then this is the treatment. Obviously, you go with radio frequency ablation or complete excision of the nidus. Okay. Again, congenital condition, you have CTV, DDH, and miscellaneous. So those CTV is the only questions which is expected for a 10-marker question. So we'll discuss only about CTV, but even Perthes is something which comes under miscellaneous for this thing, though it's not a congenital lesion. Okay. Again, CTV. In and out is important. Okay, you might have primary CTB or you might have secondary CTB. So based on that, you need to explain both the things. Okay, it can be either idiopathic, or these are the theory. It might be due to mechanical compression, or due to ischemic compression, or due to genetic. Then secondary is something where you have to always, whenever a child is born, you assume it can be due to secondary unless proven otherwise. So I have to look for any neurogenic disorders. Then there are any either multiple congenital syndrome or those things. Then you have to look for any secondary changes, so that for example, what we do is we look for spina bifida or cerebral palsy. Okay. So this is the pathoanatomy part of it. So again, while writing pathoanatomy, make sure you mention all the things. You have to talk about bones, joint, muscle tension, muscle and tendons, and also about the capsule and ligament. Okay. So this is the pathognomonic feature, that is cave. You might have excessive arching. Then you have sorry, what does cave stand for? I think you all know that. So mentioning about at which joint is something which is very very important. So that is this cavus is at the subtalar joint, then at the mid-tarsal or talonavicular joint, and varus deformity at the subtalar joint again, then equinus at the ankle joint. Okay, so again you have to mention about which where because this can be independently as per 3 marker asking you about the cave and at which joint. Then again, clinical feature, these are the same thing. It's basically patient presents you with deformity. Deformity is the major clinical symptom. Aim of investigation is to do general examination and rule out secondary causes of CTV. Then go with local examination where you do with screening with the shin test. Then if it is required, then you go with all these things. Diagnosis, obviously you can diagnose via X-ray if the foot angle is less than 35 degrees Celsius. These are the principles. The maintenance part is something which is worrisome to any orthopedician because you have to wait it for 5 years. Then again, this is the treatment protocol which is just given in my story. I've just copied. So first you have to rule out the secondary cause. So then it becomes idiopathic. Then if it's a fresh case, then you go with Ponsati method. Again, see for example, what is happening? I'll just explain you the concept. Okay, we have the time. Yeah. What is happening is that first if it's a fresh case at birth, then there is a chances that you can malleate the bone as well as strengthen or the muscle. So first what we do is we will go with tendons. Okay, if it's corrected, then we'll go with splint shoes. But again, if it's not corrected, then we go with the muscle part ka release, or again we go with posterior muscle ka release, or at the end we'll go with bone ka osteotomy. Okay, first we focus on tendons, then we go with the release of all the tense tendons over there. Then at the end, if nothing happens, if it's failing again and again, then we go for osteotomy. So again, at less than 3 years you can attempt for a soft tissue release. But Evans and wedge tarsectomies all are what they all are osteotomy. So you are removing the bones in all these things, right? And also in triple orthosis, what you are doing, you are fusing the joint. At the end, you have to go for X-Zero and do the stuff. So I know it sounds tough, but learning to concept. Okay. Again, these are the they might ask you for 3 marker. What is Dennis Brown sprint? How it is you? Make sure you have to fill for 3 marker or 5 marker. No, you can write as definition of its use and pictorial diagram. There's nothing extra to explain, but it's not used. We have all. How do you expect him to go use this throughout the life? Till 5 years, it's not possible. We have other alternatives, so these questions is meaningless. But again, they have the potential to ask for 10. Again, DDH important thing. This is the major etiology which they say. All these things you can mention. There is nothing else for me to explain. This can come as your MCQ or 3 marker also. Okay, Barlow's test. There is nothing. It's a 2-step procedure. First, you put your fingers on GT and on thumb, then adduct the in. Or if you observe an abnormal possible movement behind the GT, then it's normal. Otherwise, it's already dislocated. Then you try to abduct the limb. Again, the same thing. Treatment aim is to achieve reduction and to maintain it so that you provide clinical stability. For extra management, if you want to know, you can refer page number 219 of my show. Okay. Nothing less. Then the miscellaneous condition, major thing is Perthes disease. Though it's not being asked, but it's an important 5-marker bar 3-marker provided. This is a favorite question for your examiner setting the thing. So what happens here is stages important. So first, last stage of synovitis, then trabecular bone get necrosed, then again it heals. Where is it happening? At hip joint. Etiology again, idiopathic or steroid use. Major examination is limitation in abduction and internal rotation. You have to mention about that. Then X-ray again, it's some major investigation is MRI. If you have to pick it early, at X-ray only at the later stage you will find all these features. Okay. Aim. What is the aim? What are the 3 aims in Perthes disease? To prevent it from misshapening at the time of ossification, that is softening phase, and to maintain range of movement around it, and to prevent the deformity. So again, based on the age of presentation, if it's less than 6 years, so again you give analgesic for synovitis and physiotherapy. But you should advise all this time. You have to advise them. You have to avoid high impact sports. Again, from 6 to 8 years, you have to assess the extent. based on this Herring's formula. Then if it falls under A, you have to go with conservative part of the treatment. If it's from B to C, again you have to go with containment therapy. Again, non-surgical things are preferred over surgical, because after 8 years the surgical is the only option which you have. Okay. Then again, coming to Page's disease, can possibly come for 3 marker. These are the phases: lytic, that is when the bone is getting lysed, then it will come into both forming and lysed, then at the end it will go to formation. Okay. Again, these are the investigation, the same thing. Again, the treatment, you go with bisphosphonate and IV zoledronic acid, and if you want you can go with surgery. Okay. Rickets, though it was usually assessed a 10 marker in RS2 and RS3, now the trend has changed because of its reduced incidence, or even there is nothing much to write for 10 marker here, though this can be expected for 5 marker, but for sure you will get either 3 marker or 5 marker. So know about that. Again, though I have written all these things to know, I don't think it's necessary, but you can just go and refer. Right, while writing the clinical feature, make sure you divide it according to system, like how I divided. Draw a picture. I'm sure you know all that one baby which is there in every photo. Make sure you write about that. Again, draw it. Write with respect to cranium what is happening. Again, write with respect to chest what is happening. Again, write with respect to bones. I will talk about that in the X-ray features, and any deformities like bone neck or bone legs or knockings. Okay, and any other things. So make sure you write accordingly. Okay, major, these things are like very very important. In and out of rickets you should know, because it's like 3 marker ka short question. Okay, then radiological features. First you have to write, since it's a 3 marker, you need to expand the page, or it can be possibly as a 5 marker. Before it was a 10 marker. So what are the X-ray which you are taking? X-ray of wrist and knee joint is what we are talking about. So what are the deformities which we are able to see? One thing is, at the because of the appearance at the growth plate, you will see cupping, fraying, playing, and also widening of growth plate. And also if it's a proper bone cutting which you have to say, then you can talk about osteoporosis and cortical thickening also. Or either you can also classify it in this way. You can talk it about epiphysis, metaphysis, and diaphysis, and place the clinical features or the investigation thing accordingly, so that you get better marks. Then these are the deformities, that is you can get either genu varum, and in older you get valgum. What are the other investigation? Obviously to look for other metabolic diseases, you do all those investigation. Okay. Again, treatment aim, though the incidence is less now, 1 or 2 cases per year you will definitely see. Okay. To achieve the adequate mineralization, obviously give vitamin 6 as well as calcium supplements. So after 3 to 4 weeks you call them for a follow-up. Then again you repeat the dose if it's not being under control. Even if it's not under control, then you diagnose it as refractory rickets, then refer to endocrinologist. Again, to relieve symptoms, obviously you give NSAIDs for pain. Again, to prevent all these things, you have to do all the again based on the age of presentation, either you can go with conservative or operative. Again, osteomalacia, if this is happening in adults, then it's called osteomalacia. Here the major thing in early stages, though it's non-specific, you will have bone pains and muscular weakness or spontaneous fracture due to pathological thing at the end. Again, here there is nothing else, the same principles. Okay, not talking much. Osteoporosis, again for a 5 marker or a 3 marker, it's an important thing. Etiology, I'm sure you know it. Make sure you don't forget the endocrinal part. Clinical feature, they are obviously asymptomatic. Most of the cases which we diagnose are based on pathological fractures which become about. Again, to look for complication, you do the X-ray, though this is what we see in clinical practice. Again, to confirm the diagnosis, we do something called as DEXA. I think I'm sure you know about it. Again, the treatment aims, this is the treatment aims. You have to prevent fractures, so you have to do both bracing and exercise, that is weight bearing exercise. Again, to elevate the pain, you have to give NSAIDs, and to build the bone, you have to give calcium as well as bisphosphonate as the major thing, and also vitamin D, or at the end you can go with teriparatide aspects. Okay, the last part of 10 marker which I need to explain is the fracture part of it. Though these are the questions which are possibly can be asked for 10 marker, but I feel these are the only part where they can ask 10 mark. Though these are there, While writing, make sure you know all these things, but while studying, make sure you know all these things, but while concentrating our day before exam, make sure you know only this thing, these two parts. Okay. This is again based on my Maheshwari or singing. Okay. So again, anatomy of bone ka thing. Again, the classification of fracture part. I'm sure you would have studied from long back, like how to go about it. So again, this is your favorite, even your posting ka, end posting ka exam ka question. So again, make sure for the basis of pattern, draw one point and present all the spiral, transverse, oblique, segment and comminuted, so that you know you fill the page also, you save the page also. I mean, you do both. Okay. Again, break in the continuity of bone, I'm sure you know it. Then stages of fracture reading, again hematoma, soft callus, hard callus and remodeling. Again, this is like the pathogenesis of how it happens. Then factors affecting fracture reading, yes, it's an important, divided into patient related factors, fracture factors and surgeon factors. Okay, they, because different people have different types of reduction and immobilization. Again, fracture factors, as I mentioned, this is like a general important thing which everyone should know, so I'm not discussing much on it. Okay. Then approach to patient with limb injury, there are no RS questions. And complication of fracture, yes, can it be asked for 10 marker? I'm not sure, but for sure you will get 5 marker or 3 marker question for it. Okay. Again, delayed union is not equal to non-union. In delayed union, there might be union at the end, but in non-union, you can definitely expect no union in this. So after 6 months, you should clinically diagnose it as non-union. Though, why it might not unite? Either you are not giving the biology, that is, either there is no blood supply, or you are not giving the necessary support or necessary what do you say, traction. Yeah, that thing. Okay, so, or it might be due to both. So it is atrophic, hypertrophic or oligotrophic. Again, causes, patient factors related to the fracture itself, that is in the distraction at the fracture site for especially atrophic kind of thing or oligotrophic, and related to treatment, which I will show. Then diagnosis, it's usually in relation to time, that is, it should be more than 6 months. Okay. While writing about the X-ray, make sure you write about this thing, rounded, smooth, clear or tip thing. That's the major thing. Okay. Identify, because you need to identify the type, so that you need management depends on that. For example, if it's just an hypertrophic, then you have to remove the callus. But if it's an oligotrophic, you need to give bone graft, all those things, because you need to provide the biology, and also you need to provide stability. Okay. These are the general measures, and what do you do for different? Okay. Again, you have to go for rigid fixation. Okay. Malunion, while uniting, it has united in a malunion kind of fashion. Okay. Again, same thing, you can expect it for 3 marks. So I'm not discussing much. Okay. Then myositis ossificans, yeah, it's a proper 5 marker or 3 marker as repeatedly. So what happens is, after a bone injury, if you do a lot of soft tissue massage, then obviously you can have myositic for ossificans, or even due to neurogenic cause you might have it. So here major thing is this is the X-ray cuff region, I'm sure you know. So prevention you have to talk about. If it's an active stage, rest and NSAIDs are given, but if it's a later stage, then the only thing which you can do is physiotherapy or surgical excision. Compartment syndrome, yeah, I'm not written the definition part, I'm sorry, you can just go and write that. But one thing which I still remember is, in a closed osteofacial compartment, that is one thing which you should know. Make sure you draw the diagram, and it should be more than 7 to 10 millimeter mercury of separation. Again, where is it more common? Lower limb, tibia and fibula. That's where the more compartment syndrome are seen. And this is the pathogenesis. Based on this, you just accrue and go. This is the Eaton and Green cycle. Again, it's a clinical diagnosis. You don't wait for patient to develop till the pulselessness. Though you just even the pain on pain and pain on placiflexion is almost diagnostic of a compartment syndrome. What we do is, it's fasciotomy. That's the major thing. Though if it happens here at the end stage, you can go with the middle 1/3 of fibula. Though not done, just it's mentioned in the book. So I mentioned in the later stage, if it's not feasible, if it's not viable, then you go with amputation. Then again, injuries around shoulder. Yeah, it's a possible 10 marker. Even I agree. But most of the time it's as per a 5 marker. Okay. Again, clavicle fracture, I'm not talking about that. Only management part I will talk. Again, you go with either figure of 8. If it's a neurovascular deficit part, then obviously you go with open reduction, internal fixation. Again, mechanism of shoulder injury, there's nothing. Either you can have anterior dislocation, posterior dislocation, or inferior dislocation. Based on anterior dislocation, these are the place where that bone can go and sit, either in the peritenoid or the subcoracoid or subclavicular. Okay. Again, the same clinical feature. It's a OPD based diagnosis. Whenever a patient comes to you with the hand on the opposite side, definitely I'm sure you could, just by seeing you can suspect that. Again, these are the tests. Make sure you write all the name of test and mention about the neurovascular examination. Dugas test, Hamilton ruler test. I'm sure you would have discussed much extensively in your clinic. And obviously, these are the major aim is to prevent recurrence. Okay. Then to provide traction, you go with, this is the mnemonic which you can, I'm sure everybody knows this, or you go with traction, external rotation, adduction and medial rotation, followed by immobilization with the chest to arm bandage for 3 weeks, followed by you have to go with exercise also. Okay, these are the complications. While writing complications in orthopedics, make sure you divide it into early and late, and make sure you mention it accordingly. Okay. This is the major important 10 marker, which is like almost sure. And these are like important 5 marker or 3 marker. Again, Volcan ischemic contracture is due to a complication of compartment syndrome if not taken care of. Okay, just go to the part. I'm sure you will definitely understand what I'm telling to say. Again, where and all it can happen. This is the Fuchs injury. Okay, while writing what are the injuries which are possible when the fall is on outstretched hand, classify it as under wrist or forearm. You can have Colles fracture or Smith fracture. In elbow, you might have supracondylar humerus fracture. In shoulder, you might have proximal humerus fracture or clavicle fracture. Okay. Then this is about the Cartland classification. What happens is, again, you might have whether it in the extent in the part of the injury, you might have undisplaced fracture which falls under 5 to in type 1. If it's a displaced, then you see how is the angulation. If there is angulation, then it goes with type 2A. If there is any rotational displacement, then it will go to type 2B. If there is complete displacement, then it's type 3. Type 4 is again due to persistent if it's basically it's gone. Okay, again, mechanism of injury, these are the mechanism on how it goes, and this is the pathoanatomy. You can just read about it. And again, clinical feature, movement, investigation is obviously that. Again, this is the investigation protocol which you need to follow. Okay, major aim is to prevent malunion and prevent gunstock deformity. That's the main thing. So whenever this patient comes, obviously you check for radial pulse because neurovascular assessment is must. Then if it's check whether it's displaced or undisplaced. If it's undisplaced, put POP and send. If it's displaced, then again you have to do a closer reduction if it's possible under general anesthesia, or you can go with K-wire fixation, but though it's not done, then again you have to go with this thing. Okay, if it's abnormal, then immediately close the reduction. Look for the vascular bleed, control it, then again put a slab and come back. These are the complications. Again, immediate, early and late. Make sure you mention all these things. Okay. Gunstock deformity for 3 marker, they might ask nothing much. Is it required? It's left to patient. Colles fracture, not possibly for a 10 marker, but for a 5 marker, I think in and out you already know it. There's nothing extra for me to explain. One important thing is make sure you write the operative principles well. Okay, you can either do basically, even with conservative method in old age it might not heal, but at that age cosmesis is not problem. The major aim here is to prevent any other thing. So one thing which I would mention is here about Sudex osteodystrophy. Though you would have operated, though everything looks fine, they might have something called as functional pain. So never operate on this patient. Okay. In during Sudex osteodystrophy. Then Smith fracture, again ulta of Colles fracture, obviously the same thing. Gallese fracture, where is the depression? At distal radial joint. Okay. Fracture part, there is nothing for me to explain. Again, here in the upper, this is with the dislocation of head of radius. Okay. Again, dislocation of hip, posterior more than anterior more than central. Make sure these are the mechanisms of injury. Again, pain and swelling. So, and you can mention about the deformity as well. This is the investigation, though it's a clinical diagnosis. In X-ray, you see the breach in sentence lines. And also have to do log neck of femur fracture in old breach. So I need to mention about that as well. Treatment is again to fix it in the acetabulum and to prevent further complication. Okay. Again, the same. Whenever you write complications in any fracture, divide it into immediate, early, and late. There's a in Maheshwari itself has given it very clearly in the complication of fracture part. Form that template, go with the same narration for all fractures. For all fractures, obviously you can write all these things. No, this is specific to something. Again, for all early immediate thing, you can write about bleeding, then about dislocation, then instability, all those things. So make sure you know that. Neck of femur fracture, yes, it's an important 5 marker. Possibly they can ask that for 2 marker also, I'm not sure. So this is the classification. There are many classifications, but this is what for prognosis or planning treatment we use it. This is just to know where is it happening. Okay. Then again, for Gardner's classification is just to know based on how is this getting displaced, whether it's incomplete, complete, or incomplete. Okay. Again, any female with severe trauma who has pain in hip or near the buttock sees neck of femur fracture unless proven otherwise. Okay. So based on that, you need to work up the patient. These are the same clinical feature. Major thing is due to deformity, they can also present, or major presentation is due to pathological fracture. Again, investigation here, one more important thing which you forget is to diagnose secondary via DEXA because of osteoporosis. Okay. Again, neck of femur fracture ka management, you can refer Maheshwari, though they have not asked it many times, so I have not mentioned it here, but it's an important thing. Again, while writing the complication, use the same format: immediate, early, and late. So I have written only specific things for neck of femur fracture, for example, AVN, non-union, or osteoarthritis. Okay. By this, you have completed the major important topics for ortho as specific. Okay. So what are the things which we discussed? Again, so I discussed all the fracture part, musculoskeletal infection part, TB part, and metabolic bone disease part, and bone tumors. This will follow easy narration, but this takes lot of time. So make sure you study that part first. Okay. Now based on this, obviously you can definitely go and tackle all your other problems. Okay. So again, other fractures and degenerative condition and degenerative diseases, and these two falls under same things, but has no RS question. So you need to study based on competency. This is the possible 5 markers, favorite 5 marker, and this is like favorite 3 marker. Okay. So peripheral nerve injuries, again from anatomy you are learning this. I don't think there's some need to explain here, but while writing causes, make sure you write it might be due to CNS, systemic, root, or peripheral nerve causes, and also muscular or iatrogenic. These are the possible ways. Okay. Okay, foot drop. So again, while and make sure this is proper. So you have to talk whenever you are talking about clinical features in foot drop. You have to talk about what any CNS matter. For that case, you have to talk about sensory, motor, and any autonomic part here. Though autonomic is nothing over here, I have to talk about sensory. Where is the sensory loss? Where is the motor loss? That is foot drop, which you need to talk about. Then obviously you have to know where is the disease and what is getting affected. Based on that, if it's a CNS pathology or degenerative pathology, you need to treat accordingly, or else you need to plan the management accordingly. Okay. Then coming to claw and okay, there's one more question which is missed here. I will make sure this is uploaded properly. Okay. Even while writing the management part of it, you should know the clinical feature. Though it's a pure motor now, you can just mention it. Okay. Again, though you will just write about this, make sure you write about this as well. Even I am unable to know what question is this. Okay. Claw and these are the causes. It might be due to isolated ulnar nerve injury or both median and ulnar nerve, or due to systemic conditions like leprosy. These are the signs which you see. Uh, then treatment is modified accordingly. Again, you go with whether if it's you divide it whether it's neuropraxia or axonotemesis or neurotemesis. Here, just rest and use some nerve stimulants, regrowth, which helps in nerve regrowth. Here, based on what is lost, if it's less or if it's more. If it's more, obviously you need to go for transfer. If it's less, then you can suture it. What you will do transfer? Either you can go with nerve transfer itself or tendon transfer. But here you have to counsel the patient to go with the rehabilitation part of it. Okay. In arthritis part, RA, in and out of RA I have discussed in paper 1 of medicine under rheumatology. So I expect you to know that. You go watch that. And also gout also I have explained there only. Though hemophilic arthropathy is it's only as one, so I am not talking about that. Deformities in RA and Charcot joints I will talk about. Deformities in RA, while writing that, obviously you know it's a small joint predominant disease. So you have to mention about each and every part. What happens in fingers, what happens in wrist, what happens in foot, and other any rheumatoid nodule. So what happens in fingers? Obviously you see swan neck deformity and bottom deformity. In wrist you see ulnar deviation, and in foot you see Alex Paris. Okay. What is Charcot's joints? It's a progressive destructive joint disease due to diabetes mellitus. So management is, if it's infected, give antibiotic, or it's a non-weight way. Okay, soft tissue. See, I don't know how. I don't know why it's just remarkable. Okay, in and out of orthopedics OPD, you will definitely have someone with joint soft tissue problem. Though you might feel it's just less weighted topic, but it's important for you to study this part. Okay. Though there is nothing for me to explain here, tennis elbow is due to. This should be more than enough. So again, talk about prevention and pain management. Again, decurrent stenosynovitis, what happens? Abductor pollicis longus, that is EPS tendon, is getting affected. So what is the sign which you get positive? That is Finkelstein, where you ask the person to do ask him to adduct the thumb and ask him to bend it down. So based on that, you follow the protocol. Whether if it's a conservative or in the chronic setting, it's better to do an excision operation. And in trigger finger, what happens to the pulley? Pulley is getting due to constriction of the fibrous rigidus sheet. This you will have that click sound, which if you have seen those cases, and you can also feel for the nodule which is present. Again, ganglion cyst, I think you would have seen this same, right? But while mentioning, make sure it's transilluminant. Okay. So aspiration of cyst is known to reoccur. It's best to go for excision, or you can manage it conservatively. Then again, CTS, make sure you write all the causes. So to think in such a way where you are getting any deposition. Only in pregnancy, what is the treatment of CTS? Wait till pregnancy. That is, but in other cases, what do? You go for carpal tunnel release. Okay. These are the tests which are positive. I'm sure you know it. Again, you give B6, known to improve Nauka thing, and this is the major thing. Then frozen shoulder, I think in and out of things you know, but the first thing which gets restricted is internal rotation. Again, these are the things. If the pain is very severe, then you can give intralesional cortisone or triamcinolone. But you advise for this, and this is not requirement, because by 7 to 8 years of age, it will get recovered on its own. So you should know when to operate and when not to operate. A good surgeon is a person who knows when not to operate. Then degenerative diseases, these are the degenerative diseases which are there, though they can be as for 5 marker, but it's a predominant 3 marker disease. Again, explaining scoliosis, there's nothing, whether it might be due to structural or non-structural cause. Then these are the deformity, and how do you plan? It's basically a conservative treatment like Boston braced or any cast is what we do. Then kyphosis, that is excessive backward convexity of spine. Either you might have round or angular. Then spondylolysis, let me explain this. Okay. If this pars intermedia or interarticularis is being affected, then it's called spondylolysis, where you see Scotty dog with collar. But due to this, if this is moving front or this is moving back, then it's called spondylolisthesis. Don't get confused. Okay. Though there are many causes, this is the most common. That is due to spondylolysis. You might have spondylolisthesis also. Okay. Again, what is the one thing which I have to mention? You get that step above in the sacral test. Okay. And also you have to do SLRT to look for any radiological neurological deficits. Again, divided into 4 parts. Again, right, stage 2, stage 3, stage 4. Again, this is what we follow. If there is a neurological compression, then it's an immediate indication to go for surgical decompression. Degenerative disorders, though osteoarthritis is the most common thing, I don't know why they just ask for 3 marker, because it's something than radiological features. You should be able to pick up osteoarthritis just with crepitation, which you see, or also effusion. Though these are seen at last stages, but at least at that stage you will be able to pick these things. Okay. Again, while writing radiological feature, talk about joint space, because that is what we see first. Then talk about the bone. Then talk about the alignment. What happens in joint space? Asymmetrical joint space reduction. Symmetrical joint space reduction is seen in RA. And again, because of this, you will have subchondral sclerosis. So what does it mean? So this is the synovium. So when the whenever there is a damage to the chondrium, another bone gets deposited here, so that causes subchondral sclerosis, and this might get leaked and you can form cyst, that is subchondral cyst, and obviously osteophytes can be formed. Okay. Then these are the genu varum and joint deformity thing. Again, treatment in and out you should know, but for 3 marker, this is what is important. Chondroprotective agents. One cartilage is damaged, you cannot do anything except surgery. Then treat the symptomatic thing. You can either give analgesic or intralesional or intraarticular transdermal. Then supportive treatment like weight reduction and local heat and stress exercise are something which has to be mentioned. The last part, that is the skeletal trauma part, these are the chapters which are there, but I'll be discussing about that. Then again, classification of fractures, I know most of you know it, 1, 2, 3, and again A, B, C. Here you have vascular injury, but you don't have vascular injury. Here it's there is moderate soft tissue, but it's an open fracture here. Then again, what is stress fracture? Because of the metatarsal. Just remember about the March fracture. Then treatment is same principle. Okay. External fixators, again the same thing. What I have to remember? Elizardo fixator. This is like of a 3 marker question. Okay. Actually no. Then 3 marker itself, plaster of Paris or external fixation. So write about the chemical name, then types, then uses, then indication and complication. Okay. These 3 things. So talk on these 3 things. There is nothing for me to explain here, because something which you should know. In general overview, you have to talk about osteotomy, then all these things again for 3 marker only. If you have time, you study this. Okay. Orthodesis is what? Fusion of joint. Okay. Then again, tendon transfer, I think I had told you what these are the indication, and you should know when you do it. Then short wave diathermy is nothing but your using high frequency electromagnetic waves, so to produce heat, so that it gives pain relief or soft tissue relief in that particular joint or any position, but it's contraindicated in sensory losses or in pregnancy. Again, hand injuries, this can be expected for 3 marker, Bennett's or Mallet's fracture. I think there's nothing for me to explain here. But here major thing is you go with K-wire fixation. Either you can attempt closed reduction or open reduction. Mallet finger, again it's due to this is getting over extended, then you will get mallet finger hyperextension. Okay, that's one thing. Then the fracture patella, again, if it's comminuted fracture, then you have to go with removal of all patella. But if it's undisplaced fracture, then you can attempt for uh, uh, what do you say, POP, till the groin and till the malleolus. Otherwise, you can go with tension band wiring whenever in patella, also even in your molecular non-fracture in near the elbow, you go with tension band wiring. But basically, you have to write about what I say is whether you have written about this and about the tension band wiring. Then anterior DOAD test, again same thing. There's nothing for me to explain. Again, buses around me, not as, but make sure you know it. Divide it. It's an anatomy question. Okay, ankle injuries. Again, there is a classification. If you want, you can study, but I don't think it's that important. Okay. Joint fracture, again, it's a base of foot metatarsal. That's one important thing. Then yeah, though these are asked, but one question which they have asked is triple deformity of knee. So make sure you know that part. That is flexion, valgus, and external rotation. Where is flexion happening? That means you are unable. There you don't have ability to fully extend your knee. Then there is lateral angulation of leg. Okay. Then external rotation, that is tibia is rotated outwards relative to the femur. Okay. So just know that. Okay. This is like short 3 marker. Okay. They might talk you about Thomas Pliny. So that's what here. What happens is you have to write only 3 parts. So nothing much, nothing less. So write about the definition. You can draw the diagram if required. 1 second. This is the diagram. Make sure inner bar and this is at an angle of 120 degree. Why was this found out? To treat, to manage immediate management of shaft of femur fracture. Okay. Then again, this is the one more splint for the same thing. Okay. Then amputation part, again you can expect it just for 3 marker. That is, you are removing the part of the limb. Either these are the indication. Then based on the level, you have different names. Aboni, Biloni, then all the other parts which is there. So if you just go through this, there's nothing. So whenever you are getting a 3 marker ka question, write definition, indication, contraindication, or any specific thing which they know you to expect. Okay. And seems not talking. This is like, I think you have seen this in your Jaipur footage scene in where CT. So you can talk about it. And then crutches, nothing less. Then these are the miscellaneous chapters which are there. You can refer that. So I request you to just go through these chapters. Though you have less amount of time. Make sure whenever you are studying before that, you can just study about this. But a day before exam, don't waste time on this. These are the topics which are there. Torticollis is an important 3 marker, so make sure you know it. So cervical rib is also important. Only if it's there is a vascular or neurological complication, you go and operate. Otherwise, you don't touch that. Okay. Then genu valgus, in and out. I think you know. There's nothing more I have to say in that. And even the popliteal cyst and loose bodies in joints. I have to just refer and go. So yeah, I'm aware that I have not explained many things in ortho this video as I explained in medicine, because here the principle on how to write a narration remains the same. There's nothing more which I can explain. So my aim in this ortho revision video is that, see, 10 marker, you need to study only 4 things which I have mentioned. For those, you need to study properly, okay, because that can even come as even ankylosing spondylitis. I think I forgot to say that's also under degenerative condition, though that was asked as a 10 marker there. So study, but I taught ankylosing spondylitis in medicine video 1, so study that part. See, 10 markers, if you study properly, the remaining chapters on based on our division. So make sure you study at least if you don't want to watch the full video, uh, at least get the plan of action. Remaining it's left to you, because if you study all the RS questions and sit in a day before exam, you cannot finish that, because you don't only have ortho, but you also have others surgery paper too, which is pure systemic. So major aim is to draw diagrams in ortho also, like how surgery goes. So know the concepts. For example, if any complication related to fracture is asked, so you need to know the general complications, right? So it might be due to immediate, early and late. So based on this, place those diseases and place those complications, and one fracture will have unique complication. Make sure you highlight that, but for filling the page you should know all those things which you have to write. Again, for even the treatment and management part. So whenever you see, if it's involving the article, if it's involving the cartilage, then obviously what you should do, you should go and you have to do an open reduction and internal fixation. So make sure your concepts are strong. That is what I can give. For example, in nerve injuries, as I told, you have to check whether it's an neuroplaxia, oxygenetemesis or neurotemesis. So based on that, you can manage the whole. You can write the management plan for whole thing. But you should know the clinical features. You should know the management. But you cannot sit and study a day before exam about the clinical feature, because that is something which I studied in ortho. Here, the major aim is to say how to plan, how to go about it. At the end, this is to be watched either in two types. Either you are planning for the studying of the topic, so that you have a general idea on how to go about it at the end of the topic, so that you have the revisable material which is present, so that you just go about it and you just finish it off. Not before, not even early, not even less. You need not watch it during your starting of the year. Even if you can watch, you can plan it accordingly, so that you need not stress, and you can concentrate on class where you need to concentrate more. So that is the major overall. So there are 105 topics, so but we are covered medicine in just 85 chapters, because medicine has an easy narration. Even ortho has an easy narration, but the content which you need to fill in ortho is quite high. Okay, and you get the paper at 10:45. So that in our university. So you would have already been exhausted. You might already have been feeling bad for the paper on how you have attempted based on how you have prepared. So you should have that mind. So that even in the worst of the worst, this is worst outcome of paper 2, you should be able to get those marks or fetch those marks in orthopedics paper, so that you can maintain the balance of overall surgery paper. Correct. So study these topics first, and MCQ, obviously it's on the day of exam, there's nothing there, but make sure for 10 marker you study all these things. Okay, sure, because the at this time we are in the position where we are able to predict papers, because we have 10 papers to be answered this year. So I hope university also understand that and give some predictable questions. So again, in our aim of 100 markers, our aim was to predict either for 60 to 70 marks. But here it narrows down, because the number of marks itself is for 50 marks. Even if you are able to predict for 30 marks, you are about to pass. You can get this 10 marker ka one question and 5 marker ka two question under this part, which almost transfers something related to 20-25 marks, and remaining 3 markers, which one 5 marker which is sure is nerve injuries, 1 3 markers which is sure is your all this Thompson related splint or any something to do with orthodesis and instrument part of it. So study those part, never miss those part, because those are like important short questions. So study those parts, study these part, and you can answer based on these part. You can answer, I'm sure you can answer even 1 or 2 questions of 5 marker or 3 marker. For example, if rickets is not asked for 5 marker, for definitely a rickets based question will be asked for 3 marker, either the radiological features or clinical features. If a degenerative disease like RA or OA is not asked for 5 marker, 3 marker is a short question. So you should know when to answer and what to study and what not to study also. And also soft tissue related question is also sure. Spine related issue is also question is also sure. Problem for the paper setter is they have to include all related topics here. So when they have to include all related topics, so you need to study specific things in specific topics. So you need not study all kind of fractures. You need not study Jones fracture, Smith's fracture, or any other fracture, a mallet fracture, or any fracture for that fact, because it is as possibly it can be as for 3 marker. I'm saying for those people who had not studied till now. But if you are studied till now and you have to just revise and go, get full marks from everything. But if you are unable to study all those fractures, it's fine. The aim is to pass first. So for that you need to finish these topics. Even if you write something related to that, for that you should know the concept of management of fracture. So first 2-3 lessons of orthopedics is vital. not only for you to pass but also to know the subject in depth, so that you can write something about any fracture. For example, when will you do gay wire fixation, when will you do internal fixation, when will you do gross reduction and internal fixation, when do you not, if it's a non-displaced fracture, why do you go with the gross reduction, and why do you go with internal open reduction, internal fixation, except in few places. So you should know those few exceptions, and you need to plan accordingly. The aim is to pass, then to get good marks. So I hope these notes will be easy for you to come and study, or even to plan for your exams. That's it. I know it's 105 pages, but there are a lot of things are I've added extra to give you a plan, orientation, and how to go about it. So I have wasted pages on that part also, but make sure you study what is important. Only what is important. First, even while revising a day before exam, start with osteomyelitis, start with TP, start with supracondylar fracture, start with bone tumor, start with CTV, then jump to your nerve injuries, then jump to all these things. So plan it accordingly. Then even if you have time left after revising surgery, then revise mallet fracture or Jones fractures or any other things which is important. Not at the first, first you give a read, then make sure you study these things very properly, then come back and just touch upon those topics, so that you should be in the capacity to fetch 2 or 3 marks if it's asked for 5 marks, or 1 or 2 marks if it's asked for 3 marks. Okay, then you need to balance out in surgery. That's the overall aim. That's what I wanted to say. I know I'm not explaining few things, because it's not a video where you explain things, but it's a video where to guide people, where you know what to read a day before exam, or if you're planning to start a revision. Okay, thank you.